Good morning. Welcome to Symposium on Maternal Medicine. As you know, maternal medicine means care of pregnant women with a medical condition. I feel the good outcome of such situation decided by the good relationship between the obstetrician and the physician or internist. Many physicians we are not very familiar with the physiological adaptation and changes of a woman during pregnancy. On the other hand, field of maternal medicine is vast because virtually all the medical conditions could happen during the pregnancy. And there are medical conditions unique to the pregnancy, like acute fatty liver of the pregnancy and cholestasis of the pregnancy. These things happen only during the pregnancy, and we physicians are responsible to manage those conditions. Today, we have selected 3 important topics in maternal medicine, and we have got 3 eminent speakers. They are going to talk on these areas. The first speaker is Professor Teratogenic Galapatti. She's a consultant physician from University of Colombo. She's going to talk on prescribing in pregnancy. Over to you.
Good morning, chairpersons, ladies and gentlemen. Thank you, Dr. Priyankara, for that words of introduction. First of all, let me thank the new Society of Internal Medicine, the President, Dr. Senaka Rajapaksa, and the Council for inviting me to deliver this presentation on prescribing in pregnancy. We cannot talk of prescribing in pregnancy without speaking about thalidomide. We changed the history of pharmacovigilance about 50 years ago. In 2016, the world commemorated this disaster, and Daily Telegraph said justice has never been done and it burns away. The thalidomide disaster people are still trying to resolve this puzzle. Distaval, which was promoted as a safe sedative and method for sound asleep, resulted in these gross teratogenic effects in babies, and it took about few years for people to recognize and point this to the sedative that was given in pregnancy. So this disaster changed the laws pertaining to teratogenic testing of new medicines. Before this disaster, teratogenic testing was not made mandatory, but after that it was made mandatory. And in fact, the yellow card system in the United Kingdom of spontaneous reporting came into being after this thalidomide disaster. It also changed the attitude towards medication taken during pregnancy, where there was a resistance to take drugs by women, as well as some resistance to prescribe the drugs by the doctors as well. What are the problems that we have in prescribing in pregnancy? We have to balance the benefit versus risks as we do in all other situations. However, this evidence that we talk about is quite limited in pregnancy, because, as you know, there are very few clinical trials that are conducted among pregnant women, and therefore we make the therapeutic decisions based on the weakest level of evidence, coming mostly from case reports or from case series or retrospective studies particularly. If you talk about the magnitude of the problem, 1/3 of children born in the UK are due to unplanned pregnancies. And the potential teratogenicity needs therefore considering whenever we prescribe for a woman of childbearing age. And the studies have shown that about 50% of pregnant women will take a drug at some point in their pregnancy. So therefore, talking about prescribing in pregnancy and the issues involved is quite relevant. When you look at the published studies on prescription drug use in pregnancy, this study coming from the US looked at the drug exposures, particularly the drugs categorized according to the older system, categorized under category D or X, and it showed that about over 3,000 patients have been prescribed in pregnancy, mostly in the first trimester, these drugs. Talking about this previous US FDA classification, category D are the ones where there is positive evidence of fetal risk, but the benefits may be acceptable. Good examples are the anti-epileptics. And then category X are the ones where there is definite risk, and risk clearly outweighs the possible benefits. Good example is thalidomide. So when looking at the most common US FDA category D and X, you can see the number of instances where it was where these category X drugs were prescribed. Particularly of note, drugs like statins, simvastatin, even warfarin, and other statins have been prescribed. Exact numbers of women, like 280,000 women in USA alone, according to this study, out of 4 million pregnancies were exposed to these drugs in pregnancy. Right. Talking about teratogenic risk, it is determined, as you know, by the time of exposure, and the greatest risk is from the 3 to 8 weeks of conception. And teratogens are classified as substances which cause congenital abnormalities or abortions or other structural defects. We know that teratogens act with specificity, and they demonstrate a dose-response relationship. And sometimes genotype of the mother as well as the fetus can affect the susceptibility, and the effects depend on the timing of exposure, which is shown in this dysmorphogenic calendar. It is fortunate that in the first period, which we refer to as pre-embryonic phase, lasting about 0 to 17 days post-conception, we have all or none law, because the pluripotent cells can either fully correct the abnormality or it will result in a miscarriage. And the critical period is this teratogenic period, where it is 3 to 8 weeks of post-conception, where we get all the severe teratogenic abnormalities. And in the fetal phase, which is after the 9 week of post-conception to birth, we get fetal growth affected. So this slide shows this period. So as you can see, the first, okay, it's all right. You can see that the first 2 weeks results in prenatal death, that is the all or none law period, and then the 3 to 8 week period is the typical period of teratogenicity, and subsequently it is the postnatal period. Following that, you get, okay, yeah, that's it. Following that, you get the period of fetal development, where still some of the drugs can result in effects on the fetus. So the major malformation risk in general population is about 2%, and some of the medical conditions may increase that risk, for example, even in patients with epilepsy. And drugs associated with an increased risk do not affect the majority of the exposed fetuses, well shown by anticonvulsants, where about 90% of the patients do not develop any major structural abnormalities. However, and teratogenic effects that are shown in animals may not be shown in the humans. A good example again is corticosteroids, and we know that the teratogens must reach the conceptus through the placental barrier to give the effects. So the placental barrier, like the brain, protects the fetus from the environment, and so therefore a barrier similar to the blood-brain barrier is located in the placenta, which separates blood from the mother of the fetus. And the lipid-soluble drugs are the ones which can readily diffuse this barrier, where within 5 minutes of taking the drug, some of these drugs can reach about 75 to 100% of the concentration that you see in the mother. Another problem in the when the drug reaches is the fetus lacks the barrier that the mother has against drug reaching the brain. So therefore, fetus lacks the protection that the mother possesses, because the fetal blood-brain barrier is less developed. So that is why now there are several studies which are showing that there are effects on the brain of the baby if when exposed to the drugs in the fetus. And when we talk of effects of pregnancy on the drugs, We know that the pharmacokinetics are affected because of increased blood volume, reduction of the increase of the plasma protein levels. So therefore, and also there is reduced absorption and increased elimination of most of the medicines, which leads to reduced total plasma drug concentration, and the free drug to protein binding also may be altered. So therefore, changes in the dose should be guided by the free levels of the drug or the clinical need. And we know that in countries like Sri Lanka, when we try to prescribe, most of the time, we cannot get a drug level of the important drugs, so that also hinders prescribing. Increased renal clearance can increase the requirement of the drug. A good example is insulin, where the dose needs to be sometimes increased during pregnancy. Drugs like lamotrigine, where clearance increases from first trimester to the third trimester up to about 300%, and then clearance decreases from about 32 weeks and returns to baseline within 2 weeks of delivery. So therefore, there are changes during the period of pregnancy and immediately afterwards as well, and these changes vary between individuals. So that is why monitoring of levels and the symptoms before and during pregnancy is required. Right, when we consider prescribing in pregnancy, we need to consider 3 scenarios. Firstly, prescribing for a woman of childbearing age group. Secondly, for women and as well as men who are having chronic illnesses, pre-pregnancy counseling. And then thirdly, principles during pregnancy, early pregnancy, as well as after the first trimester. Let me focus on these 3 situations now. So, considering prescribing for women of childbearing age group, I think the most important principle is we have to consider every woman of childbearing age group potentially becoming pregnant. That is the only way of preventing unnecessary and avoidable effects on the fetus. So contraception while on teratogenic drugs is very important, and some drugs can reduce the efficacy of contraceptives like rifampicin, so those have to be taken into consideration. And we have to always inform the possible adverse effects on the fetus or the newborn of untreated illnesses. We need to review the drugs with very long half-lives that have an influence even long after stopping. Good examples are drugs such as amiodarone as well as leflunomide, where you can have effects even up to 2 years since stopping the drug is there in the body. Right, so pre-pregnancy counseling is vital for patients who have chronic disorders, where women with chronic medical conditions are now frequently becoming pregnant. So in these patients, pregnancy should be well planned. We need to review the key medicines which are known to cause teratogenicity or fetotoxicity and modify the medicines accordingly. And we have to ensure that the patient embarks on a pregnancy when the disease is well controlled and well supported by specialists throughout the pregnancy. So I would like to give you some of the findings that we published last year on pregnancy outcomes and contraceptive use in patients with SLE, rheumatoid arthritis compared to patients with chronic disorders. And what we saw was most pregnancies were unplanned. You can see in this slide, we looked at the outcomes, and almost all the outcomes that we looked at, the live births, the term deliveries, normal vaginal deliveries, normal birth weight, and yes, disease flares during pregnancy, all were much higher in patients who had an unplanned pregnancy compared to those who had a planned pregnancy. We should not forget men in this exercise because they are also equally responsible for the conception. And for example, in many thalidomide-associated embryopathy occurred in children of men who use the drug. So therefore, using teratogenic substances in men is also equally important. And nowadays, isotretinoin used for in severe acne is the most teratogenic drug since thalidomide, and it is used in men who might give, result in a pregnancy and may have effects. So, and also we use methotrexate in patients who have inflammatory bowel diseases, and that can result in effects on the fetus. So therefore, these things have to be considered when prescribing for men who are having chronic disorders. Right, so what are the general principles for early pregnancy? We need to take a full medication history, including the prescribed drugs, over-the-counter medications, as well as illicit drug use. Fortunately, it is not that much of a big problem like in the West, but we are seeing it more and more in this country. I think we had some presentations at the last month's Ceylon College of Physicians where party drugs were discussed, and it was highlighted that now that is becoming a problem in Sri Lanka as well. And we had to calculate the gestation using the LRMP, and we need to stop sudden stopping or changing the drug to reduce the risk of major malformations, because once the patient has become pregnant, stopping is, generally will not do anything much, because the patient, the fetus has already been exposed, because patient is at least 6 weeks pregnant by that time. So general advice is not to stop essential safer medicines, but we need to seek specialist advice when unsure. So the general principles are you have to use the lowest effective dose and avoid polypharmacy, because that adds to the risk. And as a principle, we should not use any of the new drugs, the new chemical entities, because we get the information on the effects only after people have been exposed to the drug, and we don't have that information with the newer chemicals that are approved. Chemicals or the biologicals for that matter now in the current situation. And it is always safe to choose a drug which has been in use for a long period of time. For example, tricyclic antidepressants are preferred over SSRIs in depression, because SSRIs, there are a lot of new data coming on the effects on the fetus. We have to balance the risks of potential adverse effects, particularly on the fetus, with the benefits that will be given to the mother in treating the disease. And we have to appreciate that this balance may change during the pregnancy. For example, for a woman with inflammatory bowel disease, biological therapy in the first trimester may be acceptable because they do not cross the placenta until the second trimester. But in the third trimester, it may be reasonable to use a high dose of steroids. And in balancing risk versus benefits, we have to consider very carefully. For example, asthma, benefits outweigh the risk, as well as in epilepsy, but we all know that in acne, risks outweigh the benefits. Right, so after that period, the fetotoxic period, it can occur anytime between late first trimester and the birth, which can cause a variety of effects. And effects of the drugs on cognitive function are now coming up, particularly with brain development, because brain development occurs right up to the time of birth and even beyond. So therefore, these effects can be manifested. So that's why I said SSRIs, now there are several concerns. And these are some of the drugs affecting fetal growth. ACE inhibitors can cause renal failure, NSAIDs, renal dysfunction, and premature closure of ductus. Warfarin, we know, can bleed into the brain and cause microcephaly. Tetracyclines, the dental effects, and benzodiazepines, the dependence in fetus. So general principles is to avoid, if possible, reduce the dose near delivery, and reduce the risk of withdrawal in the neonates. However, the risk of maternal relapse may have to be taken, may be more detrimental to the newborn. For example, suicide is an important cause of maternal death, and psychiatric illness is a bigger risk factor, so they need to be adequately controlled. And if you need SSRI, fluoxetine seems to be preferable. And we need to keep ourselves updated as the new data emerge, especially for commonly prescribed as well as the relatively new drugs. A good example is valproate, because early this year, UK had several publications, and they banned valproate without the pregnancy prevention program in place. Because valproate has been shown to, in addition to the well-known malformations, there were several effects on the fetal brain development. There have been developmental problems in about 3 to 4 children in every 10, and the long-term effects are still unknown. So 3 to 4 babies of every 10 exposed is quite a high risk, and they are late in walking, and they have lower intelligence, memory problems, ADHD, and so on. This study that we published early this year, we looked at the obstetric outcomes in women with epilepsy, and we saw that valproate was used in the first trimester in about over 25% of patients. And that this slide shows that this is the first trimester valproate use, and they were changed to very often carbamazepine by the second and third trimester. So this indicates that it could have been possible to change these drugs before the patient became pregnant. So these are the things that we need to focus our attention in Sri Lanka. There are so many, several drugs which have good safety record in pregnancy. I don't want to go through the details in the interest of time, but we must select some of these. And these are the studies that have been done on safety profile on medication use in pregnancy. So the possible safe medicines and risky medicines have been identified. And the most common drugs that were dispensed are given here in that particular study. And you can see drugs like ibuprofen, the combination analgesics, metoclopramide have been used where others can be used. So now there are several guidelines, for example, British Rheumatology Association guidelines on, for example, in rheumatological disorders. Several guidelines are coming up on prescribing in pregnancy, so those have to be consulted when prescribing. Steroids, so prednisolone is compatible in each trimester with level 1 evidence. Azathioprine, which we earlier thought should not be given in breastfeeding, now is allowed in breastfeeding as well as in pregnancy. So the need for treating maternal illnesses is also very important because all these conditions have to be well controlled, like diabetes, SLE, antiphospholipid, and we must also address the contributing and confounding factors to treat the underlying illness. There are some drugs beneficial to the baby, for example, thyroxine. It improves, the brain function. So majority of circulating free thyroid hormones are particularly maternally derived, so we have to inform that to the mother as well, otherwise they might not take it during pregnancy. Recently in 2014, there was a new pregnancy and lactation labeling rule in the US FDA because earlier categorization of 5 categories A to D and X was thought to be too simplistic, and therefore this one came in where pregnancy, lactation, and effects on male and female reproductive potential also taken into consideration. So this labeling rule now requires to give more information in the product information leaflet, which will be more useful for the prescribers. So if you want to find information, first line sources would be, we look at the BNA for other online sources. Second line would be the product information leaflet and published articles. There are these Briggs is a good, continuously updated. You can find information on prescribing in pregnancy and lactation. And finally, there are these online resources. Unfortunately, they are not available free. We have to pay to get information. So that's a problem that we have in these countries. So finally, ladies and gentlemen, medications in pregnancy is a tricky business, but we need to make it safer for the mother and the baby, keeping thalidomide disaster in mind. Thank you very much.
Thank you very much, Gestational, for a comprehensive lecture. I think we can take the questions at the end of the symposium. And in real life, it's very difficult. And we were discussing with Professor Chandrika. Recently, we had a pregnant woman. She had a kidney transplant, then got pregnant. Then the medical team and obstetricians, we managed together and delivered the baby without any complication. 3 days later, she got fever. Then we thought it's due to some bacterial infection. To see it was dengue. And this immunosuppressants and steroids, we can't stop in the pregnancy. We continue those things. Again, those things are not very safe in the dengue fever. So we were able to manage successfully, and both mother and baby, newborn baby went home. So sometimes real life, it's very, very difficult. So we have to stick to the guidelines, thinking about the physiology and treat the patient and do the best. Next speaker is Professor Chandrika Vijayratna. She's consultant physician from University of Colombo. She's going to talk on gestational diabetes mellitus. Over to you, madam.
Thank you, Mr. Chair, and thank you to the organizing committee for inviting me to this symposium. So my task is to discuss about gestational diabetes, which now the new terminology is hyperglycemia in pregnancy, or HIP, which I shall allude to. But from a general physician's point of view, I think this subject is of great importance beyond pregnancy because of the linkage of the chronic problem of non-communicable disease, which is in epidemic form, which has got to link with the maternal health programs of our country and most countries, because it has a bearing. As you can see, this cartoon on the right shows that the fetal programming that occurs in the maternal womb is what would determine the future generation's risk of chronic non-communicable disease, which could be an overweight baby or even an underweight. So I would not choose any one of these babies, either of these babies, as my own, if and when. So, ladies and gentlemen, the difference of hyperglycemia in pregnancy is not just frank diabetes, but any degree of carbohydrate intolerance, first recognized during pregnancy and even if it persists after pregnancy. And overall, the implications for pregnancy are many, but from a physician's perspective, it is important to realize that a woman who has had gestational diabetes before has a very high risk of recurrence in subsequent pregnancies, as well as her own risk of future type 2 diabetes can be as high as 60% over just a very short period of time. And our experience is that women who have developed gestational diabetes develop type 2 diabetes even as an early age of mid-30s. So this kind of gives you the overall picture of the new terminology of hyperglycemia, where on the left side it is pre-existing diabetes, or what we call DIP, which could be type 1 or type 2, as well, while gestational diabetes is where pregnancy itself, the hormonal changes, would uncover the risk for future diabetes, which might occur in a pre-existing diabetic who is being seen for the first time and being tested in her life because she's pregnant, or the true gestational diabetes, which reverts back to normal soon after the placenta comes out. Because the placenta is the offending organ by producing large amounts of anti-insulin hormones. So what is the magnitude of this problem in Sri Lanka? Community-based prevalence has shown an exponential rise over the past 30 years. And I would vouch for the latter two on the right-hand side, which were properly conducted, community-based, randomly selected sampling. And you could see that this is purely gestational diabetes, excluding those with pre-existing diabetes that we would find in 1 in 7 women or so. And the fact that 10% of these remain to be diabetic in early postpartum periods. So we could appreciate that these are women that we physicians need to address even when they are not pregnant. We have a very well-structured maternal and child health program, which is essentially driven by the field worker of a trained midwife, but we have approximately 400,000 pregnancies per year and about 360,000 that carry to term. And this would mean that we have to handle about 40 to 50,000 pregnancies affected by hyperglycemia. So I thought I would start with a case scenario of a 36-year-old woman who is in her 3rd pregnancy with 1 living child, who is 8 weeks pregnant. And these are her fasting and 2-hour postprandial blood glucose values in milligrams per deciliter. And she denies she has diabetes. Now, it is extremely important, even from a physician's point of view, to look at the previous obstetric histories. And what one would notice that 15 years ago, she has delivered a child by cesarean section, and the birth weight is 3.9. Now, any birth weight over 3.5, we need to have be alert to the fact that she has developed a macrosomic baby. She has miscarried at 14 weeks, 9 years later. She has been struggling to get pregnant with irregular periods, and her booking BMI is 35, and she's hypertensive. So she's most likely to have had something like polycystic ovary syndrome, which has been kind of managed or suboptimally managed, but she does not know that she has diabetes when she's a clear person at risk. On direct questioning, we found that for 4 years she has worked as a housemaid in the Middle East, which is often a risk factor for gaining weight and developing diabetes, and that she has been actually investigated for subfertility, where someone had actually done a glucose tolerance test, a 75-gram glucose tolerance test, done an HbA1c. She was diabetic, she was asymptomatic, probably lack of communication or understanding, and there was no intervention of metabolic control. And in fact, from an ethical point of view, as to how isn't this a missed opportunities to provide optimal preconception care. As you know, we heard about teratogenicity. High blood glucose in the mother is also teratogenic and causes multiple fetal anomalies, and also would affect the mother's well-being and outcomes, as well as the long-term effects. So, in fact, we need to support the fact that if there is infertility, we need to give holistic preconception care. It should include a 75-gram oral glucose tolerance test, particularly in the setting of PCOS, which has been an international recommendation where data from Sri Lanka was also taken into account. So what about hyperglycemia in pregnancy? We need to address the pathophysiology, as our chairperson said, and also look at what targets we need to achieve through multidisciplinary inputs, as well as to adopt a pragmatic life cycle approach, because these women need follow-up postpartum and inter-pregnancy, which is often where they get missed out. So this cartoon kind of puts it into summary that a normal pregnancy is in fact a state of maternal starvation, and that on the left side is of a fasting state, and that on the right is of a fed state. And you could see that these blood glucose values are around 80 milligrams per deciliter lower than a non-pregnant person's, even in a fasting, and even in a fed state it's 120, and in fact 90 to 120 are targets in a pregnant woman with hyperglycemia who we would want to achieve, because these are the normal values. And there is facilitated diffusion of maternal glucose to the fetus, whether she's fed or fasting, and while the growing placenta elaborates more and more anti-insulin hormones, which gets back into the mother's circulation and worsen her risk of developing diabetes. So it is a dynamic situation, very different to the standard diabetic patient, almost like a patient who's had a renal transplant is on many diabetogenic drugs. So what actually happens to the fetus? This is the famous Peterson's hypothesis, which explains it so well. The placenta does not transfer insulin, but transfers glucose, so there is fetal hyperglycemia, and thereby a response of fetal hyperinsulinemia, and the baby actually does not get diabetes, but runs a risk in the long term. So in the mother, early pregnancy actually favors lipogenesis, and glucose tolerance can even become normal. But in late pregnancy, particularly in the obese older women, they develop very high, particularly hepatic insulin resistance, which can lead to hyperglycemia. So high glucose, high insulin in the fetus causes macrosomia, which we address, just as much as there can be polyhydramnios and also sudden fetal death. And the sudden fetal death is due to metabolic fluctuations, potassium changes, ketosis, and many other unexplained causes. There can be mechanical problems in delivery, and particularly shoulder dystocia is considered as something that must be prevented, while neonatal hypoglycemia is something that now that the neonatologists are high on the alert for when managing such babies. So just to go back into the ill effects on the fetus. One could see that on the left-hand cartoon that as the fetus develops, the growth, it is liable to accelerated growth due to poor diabetic control in the mother, while in the early phase, as just like in teratogenicity, if the fetal development, if we don't catch them early enough, we would miss. Those are also missed opportunities where the fetus might be at risk, particularly from multiple congenital anomalies, but just as much as those that escape congenital anomalies are at higher risk of cardiomyopathy, which it is like a hypertrophic obstructive cardiomyopathy which regresses in late infancy, while neonatal hypoglycemia, hypocalcemia, and jaundice and respiratory distress syndrome can occur to these babies. The mothers are at particular risk of preeclampsia, and this is very interesting because the placenta is such a vascular organ. It undergoes several changes, just like atherosis through lipotoxicity, and changes in the prostaglandin mechanism, and therefore they have to be really looked after because there is a very close link between uncontrolled hyperglycemia of pregnancy and preeclampsia. So this was a highly debated point as to whether impaired glucose tolerance in pregnancy can have adverse effects on the fetus. And this study, which was reported exactly 10 years ago, having been carried out for 10 years previously in 25 countries, clearly showed that there was a continuum risk for adverse perinatal outcomes, be it high birth weight, be it neonatal hypoglycemia, shoulder dystocia, or high C-peptide levels in the cord. So in summary, ladies and gentlemen, in terms of the complications of hypoglycemia, pre-existing diabetics can miscarry, congenital malformations, they can be stillborn or neonatal death, while those with gestational, which is later on, are more perinatal problems, while fetal macrosomia, birth trauma, induction of labor needing or cesarean section, and neonatal problems, and long-term obesity and diabetes in the offspring is common to both varieties, early and late pregnancy. So what about the pre-gestational variety, like what I depicted in our case scenario? Well, they confer graver risks, and therefore the physician plays a role because they should have been ideally managed preconception. Just as much as screening and diagnosis has led to a lot of confusion, not only in Sri Lanka, but in many parts of the world due to different recommendations coming out. But the more pragmatic, particularly the Indians who have a very not as organized MCH system, they really adopt the non-fasting 75-gram glucose challenge test. So some kind of glucose loading has to be given is their argument, and catch the woman when she comes and check it out then and there. While WHO wanted a fasting blood glucose and a 2-hour value, which is still being retained through the HARPO criteria, but also I will allude to that later, which is really for gestational diabetes and not for early pregnancy detection. So our principle in Sri Lanka is that the risk factor-based approach is not appropriate because we have such a high prevalence, and therefore universal screening is being adopted, and I'm very grateful to the ministry for having taken this on as a priority. Simply because our structure shows that more than 95% of women come for antenatal booking before 8 weeks of pregnancy, which is a very rare privilege. And the prevalence of first trimester hyperglycemia is pretty high. Our latest study showed as much as 3% were detected in the field, and while our tertiary clinic data shows that about 24% of our sample have had previously undetected diabetes in early pregnancy. So the majority of the women would be unaware, and that is why we need to adopt this screening principle. So as physicians, you are very likely to be referred such patients, and therefore you need to be on the alert as to how to interpret these results. Now, the other aspect is that you need to screen for end organ damage of diabetes, as well as if they've been on ACE inhibitors or statins, to discontinue, to up the folate intake, as well as to add on aspirin on the premise that you can try and prevent fetal growth retardation and preeclampsia. So the one-stage glucose challenge test, the cutoff is 140, which is done in the first trimester, while the later one is where the HARPO criteria adopted, where any one of these three abnormal values exceeding fasting 92, 1 hour 180, 2 hour 153 would show that it would be most likely that we have to adopt the principle that it is HIP. And one aspect is that if this was using the odds ratio of 1.75, that the HARPO group really took to this cutoff, while if you had an odds ratio of developing HIP using 1.5, then the 2 hour cutoff remains at 140, which would have been far less confusing. So the national guidelines are up there, it's available on the website, and the fundamental issue is fasting blood sugar is not recommended, HbA1c is not recommended, and random urine sampling nor 50-gram glucose challenge is not recommended, as we need to have a standardized approach. So how do we manage? As I mentioned before, we have to, ideally, we play a role in discussing preconception care and also long-term postpartum care as physicians. And we need to look at it holistically as well as address the unfavorable drugs and the favorable drugs. Insulin is the drug of choice in most instances, and they require frequent titration. And overall, in our clinic data, about 30% of our sample that who have actually required insulin. No doubt, the type 1 diabetics, because of the liability of hypoglycemia in early pregnancy, you might have to titrate the insulins down in early pregnancy, particularly combined with nausea and vomiting. But as pregnancy progresses, every 2 weeks you need to review your patient and also be on the watch out for ketoacidosis. While the type 2 diabetics, we need to also appreciate gestational weight gain, because if they have started obese and the midwife actually calculates the first trimester BMI, we can actually then predict as to what should be her ideal weight gain. Insulin increases weight gain while metformin kind of controls it, and therefore we can be fairly liberal about the use of metformin, but up right there comes lifestyle management, and that is where our nursing educators are of extreme importance. In terms of insulin, the first line therapy, as I said, well, we have to stop glargine and glucosilin and degludec, which are category C, while the other forms of insulin available in the market are quite in order. While metformin, like in this patient that I depicted with a high BMI and a PCOS phenotype, it is a specialist recommendation of giving metformin. So, dietary advice is now more or less standard, and they are well supported by the educated nurses of small frequent meals. There is individualized counseling and a basic plan, but basically we need to restrict calories for the obese and encourage good protein intake, and about 50% of the dietary intake to be complex carbohydrates. So it has to be with much discussion and reviews, and which we have in group therapies as well as in individualized discussions between nurses and the patient. The specific targets are that to avoid sweetened drinks and concentrates, because there are a lot of social bearing on this of encouraging them to drink flavored milk, particularly, that are considered very healthy for the fetus, which has to be dispelled. And therefore, a lot of myths and misconceptions, and also the fact that you have to actually tell them small frequent meals, interval snacks, and give them the quantities. Otherwise, if you say fruits, they might even eat a comb of banana. So we need to also be aware that throughout pregnancy, throughout the day, the pre- and postprandial levels should be targeted for both types to be the same cutoffs of less than 120, and particularly the postprandial normoglycemia. So this brings on self-monitoring of blood glucose, which is not available free of charge, and therefore we have to encourage them to buy their own glucometer or share their own glucometer, and also how to interpret it and report to us, maintaining a logbook. So overall, the targets, as I mentioned, Some obstetricians prefer the 1 hour post meal, which is based on Western data, but our usual experience of using the 2 hour post meal has been good outcomes of pregnancy. And what we encourage is to review in every 3rd day at least 2 or 3 values, and therefore over a week we get an overall picture. The insulin regimes, be it multi-dose insulin, is quite in order as to whether it should be basal bolus or premix twice daily. There is not much of a difference in the outcomes of our local data, but it's extremely important to avoid night hypos. So we encourage them to do a 7-point blood sugar series where at bedtime, late in the night, to do a blood sugar, where most often we have to prevail upon the husbands to help them. Well, what about sulfonylureas? We do not encourage the use of sulfonylureas, but there are some parts of the world where they do use it. There is some transfer, but well, that would be better than having no control of maternal blood glucose in the absence of the facility of insulin. Metformin is far safer, and it lower hypoglycemia risk, and also there is the women themselves prefer it, and the weight gain is well contained. So the famous MIG study was also reported 10 years ago from Australia and New Zealand, and they used the starting dose of 500 milligrams once daily. We usually start it at night, and you can increase right up to even 3 times a day, although we often use it twice a day, and we might add on insulin in between. So the overall outcomes of long-term outcomes on the fetuses has been very encouraging from the Janet Truman group. Well, these are the kind of myths and misconceptions. The mothers-in-law loom, and they say to take on more certain stuff, as well as the husbands also try to, there is danger that these women might get sidelined. So in summary, ladies and gentlemen, it is overall combined effort, and monitoring is very important, and regular review of these women, and also self-monitoring to be encouraged through multidisciplinary care. So I just want to re-emphasize that early recognition, preemptive action is extremely important. And this was the Colombo Declaration signed 2 years ago. Our chairperson played a major role in this, so we are proud that Sri Lanka was one of the leaders in highlighting the importance of hyperglycemia in pregnancy. Thank you very much.
Thank you, Madam, for the excellent presentation. I think again we can get the questions later. Next speaker is Professor Tilak Veeraratne, the Professor in Medicine, University of Verona. Over to you, Tilak. He's going to speak on thyroid disease in pregnancy.
Thank you, Chairperson, and I'm delighted to do the paternal contribution to this symposium in maternal medicine. And since 2 lady professors around, I try to do the paternal contribution. And my delivery is in the form of thyroid diseases during pregnancy. And during the next 20 minutes, I will take you through the pregnancy-associated changes in thyroid function tests and their interpretation, since it's important to know that there's a difference in the thyroid function test interpretation during pregnancy, and the practical issues in screening, diagnosis, and management of common thyroid disease during pregnancy relevant to the internist, as there are some relevant to surgeons as well, like thyroid nodules. So I will not be touching on that part. Now, the changes in thyroid function tests during pregnancy is summarized or highlighted in this slide. As you can see, in the first trimester, there is a rise in beta HCG, human chorionic gonadotrophin levels. Along with that, there is a rise in the total thyroxine, which get sort of flattened and throughout the pregnancy remains same. And the TSH level, which we often use to screen both types of thyroid dysfunction, is lower, becomes very low during the first trimester and start rising in the second and comes to almost the non-pregnant level close to the delivery. So this is important to remember, these stats. Now, why TSH goes down in first trimester is because HCG has an effect like TSH, and therefore it stimulates thyroid gland, and thyroid gland produces more thyroxine, thinking this is a TSH that is pushing them to produce thyroxine, and this thyroxine go and inhibit TSH at the pituitary level. So as a result, for a given level of thyroxine in the first trimester, there's a reduced level of TSH, because during the first trimester, thyroid gland is stimulated not only by TSH, but also by HCG. So both are pushing them to secrete thyroxine, but the resultant secretion of thyroxine go and blocks the TSH. So TSH is lower in the first trimester. This is important. And start rising with T2 and T3. And the estimation of total T4, because thyroxine, free thyroxine, total thyroxine is a bound form, with the increase in the thyroid binding globulin with associated pregnancy, the total thyroxine remains same, elevated during pregnancy, and it is not a good indicator of thyroid function. And free thyroxine also goes down because of the increase in the thyroxine binding globulin in the T2 and T3. So these changes are important to be remembered. As a result, the thyroid function test interpretation is trimester specific. So TSH and FT4 cutoff values are trimester specific. And in T1, the upper limit of normal TSH is not as usual. You know, if anyone asks the normal thyroxine rate, most of them remember it's 0.4 to 4. You forget about the unit. It's a micro IU per ml. It's a 0.4 to 4. It's almost in this ultrasensitive TSH. So here it is lower. And free T4 is also low. And T2, it rises a bit, but T3, it's almost remained the same. What really matters is the upper limit of normal. But you might ask whether this 4 to 2.5 makes a big difference. It does. We'll see later. Why? The rationale is that they have reported that there's increased pregnancy loss in the mothers with TSH level about 2.5 to 5. So let's say 2.5 to 4, also there is an increased pregnancy loss, which is unexplained otherwise, thought to be due to the effect of hypothyroidism. Right? So therefore, now it is important to use this reduced upper limit of normal TSH during pregnancy, especially during T1, where the pregnancy and loss occurs more due to hypothyroidism. Right. Then we'll get on to the screening. Now, thyroid diseases fulfill all the criteria for a disease to be screened universally. It is fairly common. You have an inexpensive screening test. Once screening and detected, you have an inexpensive thyroxine replacement, which will make you thyroid, and there are benefits. Should then we screen all pregnant mothers, expectant mothers with TSH? So this has been addressed at several levels, and there have been several reviews and meta-analysis on the universal screening. And currently in UK, there's an ongoing study on the continuous antenatal thyroid screening, CAT study. It has been there over the last 8 years. The continuous antenatal thyroid screening. You might wonder why such a long time. What they do is they screen and they follow up the newborns. And then they see whether those with hypothyroidism has any impact on the newborn during their childhood IQ scores even. They check whether those who have TSH levels this much during pregnancy, their IQ levels differ. So that's why it's continuous antenatal thyroid screening going in UK. And they sometimes produce reports and the literature on this. So the current advice is, based on that, and other studies that universal screening of a thyroid function is not indicated. And there are specific group which might benefit from screening. If a woman has a symptoms of hypothyroidism, definitely. But it will be very difficult to detect women with hypothyroidism being vague, you might argue. Because hypothyroidism symptoms are anyway vague, and women also, most of the time, they have aches and pains and sleepiness, and you don't know whether it's hypothyroidism or something else. So, but you have to use your clinical acumen to choose the correct person. Family history or personal history, obvious. Family or personal history of TPO stand for thyroid peroxidase antibodies. That is the antibody that is often checked, the thyroid microsomal antibody. It is available in the private sector, not in the government sector in Sri Lanka. Patient with type 1 diabetes has increased tendency to develop thyroid disease, that is recommended. History of head and neck irradiation, you know why, because of the irradiation damage to the thyroid gland. If somebody has recurrent miscarriages and impaired fertility, morbid obesity, and hyperemesis and clinical features suggestive of hyperthyroidism, because hyperemesis has an association with hyperthyroidism, not hypothyroidism, and any clinical symptoms suggestive of hyperthyroidism. These are the specific indications where screening is indicated, not universally. How common are the thyroid disease in the community? Now, in Sri Lanka studies, we don't have a single study to say that in an antenatal clinic, this is the prevalence. But I had to depend on some literature from our neighboring country, India. It has to be recent. So this study has screened, even though universal screening is not recommended, they have screened consecutive 700 patients with TSH and FT4, and they found this prevalence rates of hypothyroidism, different categories among these antenatal mothers. And according to that study, the commonest form of thyroid dysfunction is subclinical hypothyroidism. And it's alarming to say that we just now saw the gestational diabetes is somewhere around 10, 12, with subclinical hypothyroidism a little more than that. You might wonder we should bother about subclinical. Yes, we do have to bother. And the other categories like overt hypothyroidism and subclinical hyperthyroidism and hypothyroidism. What you can see from this slide is that hypothyroidism is common than hyperthyroidism during pregnancy. And subclinical form is much more common. So therefore, when I talk about this hypothyroidism as a group, I thought of giving some importance to the group of subclinical hypothyroidism. Next, the hypothyroidism diagnosed first during pregnancy, and a previously hypothyroid mother who become pregnant. So, and these are the three categories of hypothyroid mothers that you might come across either on reports or might present to you as an internist. And subclinical hypothyroidism is the most prevalent thyroid dysfunction in pregnancy. And its prevalence varies from 5 to 15 in different studies. And it's defined as TSH level about 2.5 to 10 with normal free thyroxine. So this is the same, but the non-pregnant, we consider this as from 4 to 10 with normal FT4. In pregnant, we consider as 2.5 to 10 with normal FT4. And there are two types, as you can see in the non-pregnant levels. Not pregnant women, there are thyroid peroxidase antibody positive and negative. And studies have shown that those with subclinical hypothyroidism with antibody positive do worse in terms of fetal outcome and also the maternal outcomes. And these are the maternal and fetal outcomes of different types of hypothyroidism. What you can see is that even the subclinical hypothyroid mothers have adverse outcomes like preeclampsia, preterm delivery, abortion, and also the fetal outcomes are also not the best. It may be less severe compared to the overt hypothyroidism, but they do have when compared to the euthyroid mothers. So it is important to recognize this category of subclinical hypothyroidism. And one preliminary study has looked at this, and what they have done is they have given thyroxine to mothers who are subclinically hypothyroid, and there's a category with TPO without thyroxine therapy, and there's a category with TPO negative hypothyroid. And what you see in this slide is the outcomes. The two outcomes, miscarriages and preterm deliveries, are less if the mothers with subclinical hypothyroidism with TPO positive given thyroxine. So this has led to the hypothesis that if a mother has a subclinical hypothyroidism with TPO positive, they will benefit from thyroxine, as in the case of non-pregnant. But here, the definition of subclinical hypothyroidism is a little different from the non-pregnant definition. So this led to the American Thyroid Association in its 2017 guidelines to recommend when thyroxine, when TSH is above 2.5 with antibody positive, during pregnancy and also pre-pregnancy. Sometimes when the obstetricians find no reason why somebody is subfertile, they do all the obstetric tests and then finally they find that some abnormality TSH, they land the patients with us, please advise. So you realize that TSH is high, or you also got to do something. So there is something that you can do. Luckily or unluckily, they may not have done TPO. So you can do TPO, and if it is positive, you can be a magician by giving little thyroxine and the mother hopefully becoming pregnant. Here, after so much of investigations, they ended up with a physician, and physicians with a small pill make them fertile. But ATA do not recommend the thyroxine in subclinical hypothyroidism who are TPO negative. They consider, that's a shared care. You can discuss with the mother and then discuss, look here, there is no definite benefit, and there have been some harm as well. So since there are no things to carry out now, the obstetrician has done all the tests and all this and that, and we can give a short course of thyroxine and see whether the conception can come. So it may or may not come. So therefore, ATA, American Thyroid Association, has only considered, asked you to consider. Patient with SCH will require lower dose of thyroxine. That is important. So don't give a very high dose, because thyroxine itself can make the mother hyperthyroid then. And there's a place for screening for thyroid peroxidase antibodies in TSH expectant women with subfertility and miscarriages. These are the lessons to learn. But subsequently, the latest on this topic is that also the same. So this article published recently in the BMJ, impact of levothyroxine therapy on the obstetrics, neonatal, childhood outcomes. I told you they are looking at the childhood outcomes from the CAT study, continuous antenatal thyroid screening. They not only screen the antenatal period, they follow up the childhood outcomes, whether their IQs are different, any change. So it's a systematic review and meta-analysis along with that. So even though it's a sort of so seemed large study, the number on the 3 eligible trials are only less than 2,000 mothers. And in women with SCH during pregnancy, there was no evidence to benefit levothyroxine therapy on obstetric, neonatal, childhood, neurodevelopment outcomes. Mind you, this is TPO negatives. So they have not specifically said the TPO positives have benefit. So TPO negative subclinical hypothyroidism mothers do not benefit. That's the bottom line. Now, so hypothyroidism, if somebody becomes pregnant during, this is how it is diagnosed. TSH more than 2.5 with FT4 less than for that trimester, or TSH more than 10 irrespective of the free thyroxine. That's similar to non-pregnant diagnosis. So in such a situation, what do? You start common thyroxine with 100 to 150. This 2 micrograms per kg per day is a good dose schedule to go by. But you repeat as in any other non-pregnant, you adjust dose to achieve the trimester-specific TSH. And it is important to tell the mother not to take calcium tablets and the iron tablets along with the thyroxine tablet. There may be problems with the absorption of thyroxine. If the pre-existing hypothyroid mother become pregnant, you have to assess TSH as soon as possible. And if TSH appear within the specific range, you can continue the same dose and repeat. If they are within this range, you may have to increase the dose accordingly, according to the TSH, if it is between 2.5 to 10 by 25 to 50%. And you may have to go about double the dose if the TSH level is about 20. You have to double the dose. The postpartum care, nothing much different. Thyroxine is safe during breastfeeding, and most of the mothers get back to the pre-pregnancy thyroxine dose. And now we know in the Sri Lanka, the neonatal TSH screening is universally done. And let's have a few slides on hyperthyroidism during pregnancy. The definition is as same, reduced TSH and elevated TiO. It's a trimester specific values. There are maternal and fetal outcomes are listed here. And the causes, I would like to highlight one important thing. The gestational thyrotoxicosis is not an unheard, unknown. It is a gestational because we know that the HCG stimulates thyroid gland. So therefore, overstimulation can cause little thyrotoxic features even in a normal mother. So that is called gestational thyrotoxicosis. Others are the Graves' multinodular goiter and the toxic adenoma. And this table give a good comparison of the gestational thyrotoxicosis versus Graves' disease. And important things are if somebody has very frequent and too much of vomiting, that is more likely to be a gestational thyrotoxicosis. And the test to go by if you want to make a differentiation is a TRAB, the thyroid receptor antibodies or thyroid peroxide antibody, which is more likely to be positive in the Graves or autoimmune form than the gestational form. It is important to make the differentiation because gestational thyrotoxicosis does not need antithyroid therapy. It can be managed with supportive management, with hydration for vomiting and beta blockers for beta symptoms, and no ATDs are required. Graves' disease, the exacerbations of symptoms during T1 quite expectantly because of the effect of the HCG, but later on they get resolved. If you really want to make the diagnosis of Graves, check on TRAB. It has a value because then if the TRAB is positive, you can do advanced fetal monitoring to improve the fetal outcomes. So what to do? You attain euthyroid during pregnancy if it's the hypothyroidism in pregnancy. And first line antithyroid drug is propylthiouracil, and you can, due to cost factor or anything, change over to carbamazole in T2 or T3. Start the lowest dose, unlike in other situations. Monitor with a free T4. And if there's a persistent toxic features, you may have to do a TRAB in order to see how severe this thyrotoxicosis. Now, postpartum thyroiditis is another category we need to know. But its definition is very vague. It's a thyroid dysfunction 1 year postpartum in a woman without clinically evident thyroid disease before pregnancy. Usually they are TPO positive, and they differ from Graves' disease by TRAB negative. So in the want of time, I will just quickly go through the take-home messages. So TSH cutoff values are lower and trimester specific, not 0, 4 to 4. And subclinical hypothyroidism is the commonest thyroid dysfunction during pregnancy. Check TPO in expectant and pregnant with subclinical hypothyroidism. After you first diagnose subclinical, then check TPO. And thyroxine therapy has been shown to improve outcomes, both maternal and fetal, in the TPO positive subclinical hypothyroidism, not TPO negative. And during early pregnancy, exclude gestational thyrotoxicosis, which only needs supportive therapy, no antithyroid drugs. And propylthiouracil is the first choice antithyroid drug for preconception, Graves, and all other forms of thyrotoxicosis. And checking on TRAB may be useful in some thyrotoxic mothers to improve maternal and fetal outcomes. Then you can refer the fetus for more advanced monitoring to prevent the fetus being born with hypothyroid state. Thank you.
Thank you, Professor Erythematosus, for the excellent talk. We have got time for questions, 7 minutes. And I'm sure the audience may have lots of questions from our eminent speakers.
Professor Veera. Professor Ratna, it's a question about this TSH reports and the free T reports which you get from the private sector labs. Wouldn't it be time to indicate the cutoff values for the pregnancy in addition to what you sort of get 0.4 to 4? Do they put the values this trimester, this much you should? Otherwise, it's probably time for us to suggest that they do this. Thank you.
It's a very good suggestion, and to my knowledge, I have not seen the trimester specific values. They only put the, only the 0.4 to 4. That is how I also remember it as, every time. But I'm yet to see trimester specific values in. So it's a good suggestion. And I don't know who should take the initiative, but it will really serve a big purpose.
Actually, in the RIA lab of NHSL as well as at the De Souza and Castle Street, they give the trimester-specific values provided in your request form. You write that the woman is pregnant and what the POA is. So I think that it's a two-way system. I think the chemical pathologists are very responsive to it and aware of it, but the local data is being gathered now. And obviously it has to be large enough to say it's Sri Lankan cutoffs, but at the moment they are following the American ones.
This is more of observation, sir. When we request TSH, when we suspect hypothyroidism, one of the things that was told to me by my bosses that if you suspect a patient with hypothyroidism and the TSH and the free T4 are normal, suspect that the person has depression. Because as much as the hypothyroidism is prevalent in the country, remember that 1 in 4 women can any time during their lifetime becomes depressed, and 1 in 8 men become depressed during their lifetime. Thank you.
So, at any given time during life, maybe reactive depression goes through each one of us, After your exam, after something, you go to reactive depression. So, whether you call it a depression, I don't know. So, 1 in 4, in my opinion, is a little bit exaggerated.
May I just come in on that one, please? Perhaps before we take business to the psychiatrist, you can keep it within the internal medicine family by checking vitamin D.
I think your question is valid, particularly postpartum depressions, where very often the hashitoxicosis that phase where they are losing weight and very jittery might be considered a feature of postnatal blues, whereas it might well be thyroid disease. So not that I'm talking about gender specificity, but the postpartum period being a trying period.
Sorry, just to add, I think thyroid peroxidase antibodies have been associated with various effects on the brain. So therefore, I have not seen any articles, relating to relating thyroid peroxidase antibodies with depression. But there may be, some effects of thyroid peroxidase antibodies on brain. So therefore, there might be something in what you say.
Professor Chandrika might agree with me. Whenever we get a referral, a pregnant lady with possibly type 2 diabetes, and if they are bloated, and when we check their thyroid functions, most of the time we feel that they are hypothyroid. Usually what happens, the VOG obstetricians, they are obstetricians, they are not medical people. Sometimes they don't check the thyroid function and they don't suspect it. So whenever somebody is referred to us for some other medical problem, if we feel that the underlying hypothyroid, as Professor Tilakvirata correctly said, it's very common. It's subclinical variety is 15%. I think it's our duty to screen them for whether they are hypothyroid.
In fact, another thing probably I would like to add to is particularly the patients who are having autoimmune disorders. I see patients with, SLE and those who are having antiphospholipid antibody syndrome and who have multiple pregnancy losses. So those patients particularly, and some of them tend to have hypothyroidism. The prevalence is higher because of the, common autoimmune etiology. So therefore, particularly patients who are having autoimmune disorders like SLE and other rheumatological conditions, it is better to do, I think, the TSH and the TPO antibodies, because those people, I think, are more likely to have anti-TPO hypothyroidism or subclinical hypothyroidism. And I have found that patients sometimes who are referred for multiple pregnancy loss to evaluate for antiphospholipid antibody syndrome, if those are negative, sometimes their TSH is high, and I have diagnosed few cases of hypothyroidism in those category of patients.
I think just to add that the Sri Lankan, the modern day woman often tries to start a family a bit later, and then she's older and heavier and likely to limit her pregnancy also to maybe 1 or 2. And particularly if they have these other risk factors, we do a TSH, ideally preconceptionally if they are struggling to conceive, but if not in the first trimester, we do, and use the cutoff of 2.5 to err on the side of caution to if just considering multimorbidity.
Other condition where you get mild elevation of TSH is the polycystic ovarian syndrome. I have seen so many, and I physician happen to diagnose polycystic ovary for the first time because it's a type 2 diabetes coming, and they tell the story of the secondary subfertility, and you check TSH, and then because he's obese, then you do a scan and you discover this one has polycystic ovary, and then you happen to refer to VOG. So we tend to go in that path, because when there is a mild elevation of TSH, consider PCOS also, because of the changes in the serum protein levels with the estrogens, this TSH level goes up, and so it need not necessarily be hypothyroidism, but there are changes in the TSH level associated with the PCOS.
This question is about there being a hypothesis that iodized salts have caused an increase in the levels of hypothyroidism observed in the general community. Is there any study or any sort of relevant information regarding pregnancy?
Yes, there's a recommendation of a minimal amount of iodine intake during pregnancy. I suppose now Sri Lanka being using only the iodized salt, that our iodine intake among average women is adequate, because during pregnancy level. And your question is whether this iodinization of salt is associated with the increased risk of thyroiditis. That is well documented, and even Dr. Rajaratnam and others have I have seen some papers by them initially. There was some case reports of increased rates of thyroiditis in TPO positive people when they are supplemented with iodized salt for the first time, but not in recent past.
I think we had an interesting symposium on maternal medicine. On behalf of the Society of Sri Lankan, Society of Internal Medicine, I would thank all the speakers for their excellent contribution. I would like to invite our former president, Dr. Vasantha Disanayake, to hand over the certificates of appreciation. Thank you.